Hey friends, I am Dr. B.B. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.in and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary, for the medical knowledge to general people and for reference to medicos. Today I am going to discuss about the pulmonary eosinophilia. Pulmonary eosinophilia is a condition characterized by the presence of two features in common: an increase in the number of circulating eosinophils and transient radiographic opacities in the lungs. It is classified into Lopus syndrome, simple pulmonary eosinophilia, tropical pulmonary eosinophilia, asthmatic pulmonary eosinophilia, polyarteritis nodosa. Simple pulmonary eosinophilia, it is the type 1, that is type 1 of type 3 immune reaction in the lungs to various foreign proteins as of helminth larva in tropics or drugs as in temperate regions. Clinical features: a mild degree of pyrexia and a slight cough are the only clinical findings. Diagnosis: radiographic examination shows transient pulmonary opacities and the peripheral smear shows increased eosinophilic count 500 to 1500 per cubic millimeter. Treatment consists of eradicating the parasite infestation or withdrawing the offending drug. Tropical pulmonary eosinophilia. This condition is thought to be due to allergic reaction to microfilariae in the lungs. It is common in India and Ceylon. Clinical features: there is a persistent cough with or without asthma, pyrexia, etc. Diagnosis: there may or may not be miliary shadowing on the chest radiograph and a marked degree of eosinophilia in the blood, more than 2000 per cubic millimeter. Treatment: the illness usually responds to treatment with diethyl carbamazine citrate. Asthmatic pulmonary eosinophilia, including allergic bronchopulmonary aspergillosis. This condition is usually due to combined type 1 and type 3 immune reactions in the lungs to the fungus Aspergillus fumigatus. The allergen responsible for other cases have not yet been identified. The condition is invariably associated with chronic asthma. Pulmonary lesions are of two types: segmental or subsegmental or lobar collapse caused by occlusion of the related bronchus by a mucinous cast coated with eosinophils, which often contain fungal hyphae. This type is more common. There are areas of pulmonary infiltration in which the alveolar spaces and alveolar walls contain numerous eosinophils and varying number of lymphocytes and plasma cells. These lesions may recur at intervals for years anywhere in the lungs, but often involving the upper lobes. Bronchiectasis frequently develops in the collapsed bronchopulmonary segments. Diagnosis: the eosinophilic count is between 500 to 1500 per cubic millimeter. The radiographic appearance reflects the pathological changes, absorption, collapse of a segment or of large or small bronchopulmonary unit in the first type and an ill-defined pulmonary opacity in the second type. In case of bronchopulmonary aspergillosis, diagnosis can usually be made by mycological examination of the sputum or bronchial cast, combined with skin sensitivity tests and serological tests. In most cases, Aspergillus fumigatus gives a positive skin reaction. Positive gel diffusion test indicates the presence of precipitating antibody. Treatment of this condition is very difficult. Trials to eliminate the fungus from the respiratory tract by inhalation of natamycin are not successful. Antihistamines are of no value. Steroids may relieve the asthma and prevent recurrent pulmonary infiltrations and formation of new bronchial casts. If old casts can't be dislodged by postural drainage, they should be extracted through bronchoscope, otherwise may lead to bronchiectasis. That's all about the pulmonary eosinophilia, and in the next video I will discuss about some other disease. Thank you.